Okay, hello everyone. Welcome to our November Cancer Survivorship Consortium rounds. This is Jennifer. I'm here at the Elixir in Toronto. Just to remind everybody that we'll be recording the session today. Everybody will be muted during the presentation, and then at the end of the presentation, you'll have the opportunity to ask questions. It's my pleasure to introduce today Dr. Scott Adams, who is going to be presenting on precision exercise therapy in oncology. Scott's here in Toronto with us and is a postdoctoral fellow with the University of Toronto and working here at Princess Margaret as well. So welcome, Scott. I'll hand it over to you.
Hi, everyone. It's an honor to be here to share with you some ideas and some data around, I think, what is an exciting new direction with the field of exercise oncology, and specifically what I'll be talking about is how we might adapt a more medicalized approach to optimize patient safety and intervention efficacy for patients throughout the cancer survivorship continuum. So I got started back in this field in 2008 when I was an exercise physiologist at Hope & Cope, developing the Rehab and Exercise Oncology program at the Sequelae Cancer Center. I also served on a couple tumor boards there, including the Adolescent and Young Adult Oncology program. One of the greatest challenges we faced back then was trying to figure out how to effectively manage risks and optimize our interventions for what is a highly heterogeneous patient population. And I had to laugh as I was putting my slide deck together. I realized that fast forward 10 years, I'm still asking and trying to answer those very same questions. So let's get into it. The adverse consequences of therapies and all therapies have been well established for over 50 years. And unfortunately, our current inability to prevent and treat these conditions leads to an excess of suffering and disability, healthcare utilization and cost, as well as mortality risks. And while some of these conditions are fairly straightforward to treat, others are quite complex and involve variable combinations of treatment-related factors and pre-existing comorbidities and behavioral factors and psychosocial factors, which really actually makes a strong argument for the exploration of multi-system therapies. That's why I'll be talking to you about exercise today. So if we take what we know from an exercise physiology background or from exercise research in other clinical populations, and we map it onto some of these complex conditions, we see that it actually addresses most of the causal pathways, if not all of the causal pathways, to some extent. Overall, I think exercise is one of the most potent multi-system therapies available to help our patients. But we also know that no two patients present the same, right? So even if two patients are in front of you with similar age, disease stage, treatment history, or medical history, in the context of exercise, we know that there's oftentimes a fair amount of difference in terms of other complications and things that we need to consider when prescribing exercise. Now, for those of you that don't know, there was a recent boon in the field when the Clinical Oncology Society of Australia released a position statement supporting the adoption of exercise as a standard of care for all patients in their country, which, not too long after, a recent editorial pointed out that we may not be quite as ready as we once thought to make this change. And they really called into question the need to balance the safety of this heterogeneous population with providing access to the people that actually need our cancer exercise services the most. And the two main questions they posited were, does the evidence base adequately support this decision? And can such an approach be suited to the diverse range of cancer types and patients who are inflicted with the disease? And that second question really taps into the heterogeneity that I was talking about. So we, in response to that editorial, published an exercise safety guideline that is used here at Princess Margaret in the Cancer Rehab and Survivorship program. We wanted to provide clinical cut points and considerations for practitioners, and physicians according to a couple different domains of exercise testing and training considerations. One group being blood values, another being cardiorespiratory signs and symptoms, another being bone metastases, which we once thought was a contraindication to exercise, but we now know that that is no longer the case, as well as other physical and cognitive signs and symptoms. The idea was to provide the best available evidence-based directives to facilitate safe and equitable access to exercise programs across a very heterogeneous and potentially high-risk patient population. So given this heterogeneity in our patient population, it's interesting then that most exercise programs and studies tested to date have really adopted what can be described as a one-size-fits-all approach. And that approach is really based on the general ACSF guidelines, right? Trying to get people up to performing enough aerobic and resistance training exercise per week. But what we know when we look at the data coming out of these studies is that we will have some people who do respond to the intervention, whereas others won't, and still further others may be at increased risk of adverse events. And as we and others have recently pointed out, this type of one-size-fits-all approach isn't necessarily in the patient's best interests and not always appropriate at times. So then what does precision medicine have to offer? The Academy of Medical Sciences and the Medical Research Council define precision medicine or personalized medicine as a medical model that separates people into individual groups based on needing different medical direction, medical treatments, products that are all tailored to that individual's specific risks and responses. And medical oncology really popularized this approach by developing targeted therapies to specific subtypes of tumors. But how do we adapt to this approach to an exercise oncology context? We don't really have good evidence within the exercise oncology field yet, but back in late 2015 and early 2016, Lee Jones and our group proposed a couple different ways that a precision medicine model might benefit the field. Lee's paper was describing a precision medicine model in the terms of improving cancer treatment, and we described it in terms of modulating cardiovascular disease risk outcomes in breast cancer survivors. And it all starts, regardless of the path of your interest here, it all starts with comprehensively characterizing the mechanisms, the pathophysiology, and the time course of treatment, according to not just the usual suspects, but really looking across both genetic and immunologic factors, as well as both behavioral and environment. Right? So we really need to get a broad understanding of what's happening and what might be driving some of these complications. Then, depending on your interest, you can use that data to identify subgroups of patients with discrete risks or response profiles, and we can use that to predict intervention outcomes, perhaps, and identify groups of non-responders within our interventions. And those two sort of objectives really tie into what we would eventually target with a targeted exercise prescription. So to unpack this a little bit, the precision profiling piece really requires dense and dynamic data. So I say the data is dense because instead of just looking at the usual suspects, in this case, say cardiovascular disease, instead of just targeting those usual sort of causal pathways that we look for, we want to expand that search to include a comprehensive characterization of demographics, physical characteristics, medical status and medical history, as well as the physiologic assessments that we would normally turn to, including advanced imaging and functional tests, as well as blood-based biomarkers and multi-omic panels. And I say that the data also needs to be dynamic because we further need to track changes in all of those parameters over time. So once we profile the patients and we have an idea of what's happening in all of the different patients, what we can do then is apply different learning techniques to make sense or look for intrinsic patterns within the data that are naturally occurring but not obvious. And if successful, what we can do is identify unique clusters of patients with different sort of phenotypic profiles. We then take those profiles and enter it into a supervised machine learning approach that you can use to develop predictive algorithms based on either morbidity and mortality risk or intervention responses. So a couple of examples here. So the predictive factors that we developed within this supervised learning piece then become the intervention targets for our targeted exercise therapies. So a couple quick examples for individuals who have increased risk of cardiovascular mortality. If their profile looks like this with increased arterial stiffness, cisplatin exposure, which is non-modifiable, but VO2 peak and low socioeconomic status, an example of a multimodal sort of targeted intervention for that Phenogroup of patients might look like post-treatment high-intensity interval training with a social work and a career counseling component to really offset this increase in cardiovascular mortality risk. Whereas if you're looking at fatigue in patients who have triple negative disease, anxiety, sarcopenia, and high BMI, you might need a different combination of therapies. So here we're really talking about starting your intervention during treatment, some hypertrophic or building muscle mass-based resistance training with some moderate continuous exercise, as well as nutritional and psychological components. So you can see now that we're starting to actually cherry pick available intervention modalities targeted to the specific deficits of the population. And that really forms the basis of these Phenogroup-based precision exercise prescriptions. Now, like I said, we don't have good models demonstrating the capacity of this sort of research paradigm in oncology, but we do have some good examples from the heart failure literature. So Ahmad et al. Did a secondary analysis of the HF Action trial, and they used data from about 1,600 heart failure patients who had a reduced ejection fraction. The patients in this study underwent 12 weeks of supervised training, and then up to a median of 27 months of home-based aerobic exercise. And they compared their treatment or intervention responses to a usual care control. And what they did is they precision profiled their patients based on a number of sort of demographic or personal patient characteristics, aspects of their medical history, laboratory values, features of their quality of life, as well as exercise values. Now, they didn't apply machine learning to this, but they used a hierarchical clustering technique and identified 4 discrete phenogroups of patients. And if we look just quickly at their primary outcome, which is all-cause mortality or hospitalization, you can see, I don't think this works on the screen, right? So you can see that cluster 1 and cluster 3 had a fairly similar risk profile that was distinct from clusters 2 and 4. But when they just considered all-cause mortality, cluster 1 was in and of itself the highest risk group compared to the other 3. Another reason why I like this study is they also looked at whether or not these clusters predicted intervention or were associated with differential intervention responses. And what we saw is that just the patients in clusters 2 and 3 had a significant improvement in their VO2 peak at the end of the 12-week supervised component. But then they also looked at the association between exercise and their primary outcomes across the 4 clusters. And there were some significant differences here. What they saw was that clusters 1 and 2 had between a 12 and 30% risk reduction in cardiovascular mortality or cardiovascular hospitalization, and cardiovascular mortality or heart failure hospitalization. Notice, too, that cluster 1 didn't have an improvement in VO2 peak. So it's interesting that it's not necessarily VO2 peak related changes driving this protective effect. They also identified that cluster 4 patients were at an increased risk of adverse events, up to 50 and 60% increased risk. So one of the things that most struck me about this particular study is that left ventricular ejection fraction is the endpoint most commonly used to describe heart failure patients, the severity of the disease. But what they saw is there was actually no difference in ejection fraction across the 4 groups. So the most common endpoint used to describe them was not predictive in this group of patients. Drawing from that example, I think there's more we can do to learn about what factors may be unexpected, what factors may combine to help us risk stratify our patients. And it was also interesting that there were differential benefits of exercise across the phenogroups that didn't necessarily drive the changes in reductions in mortality and hospitalization risk. So let's work through a couple examples in oncology where I think the data is headed and some good early signal-seeking type data. Starting with how might we apply a precision exercise therapy model in a cancer prevention context. So Graham Copeland and Lee Jones recently published a theoretical paper describing how transitioning someone from a sedentary individual through acute bouts of exercise into a conditioned state may impact the tumor microenvironment. And what we see is that early preclinical studies suggest that exercise training does, in fact, reduce tumor incidence, growth, and metastases across a range of preclinical tumor models. And we also know that there's evidence to suggest that these exercise-related benefits may differ across different subtypes of disease. All of this sort of plays into the next conversation we're going to have about how exercise may optimize treatment outcomes. So within tumors, blood vessels grow abnormally, resulting in abnormal sort of structure and function. They're leaky, they don't deliver blood well, and so on, which leads to a decrease in the perfusion of the tumor and increased pockets of intratumoral hypoxia. Inevitably, when you try and treat patients, there will be a reduction in drug delivery and an increase in the likelihood of patients developing treatment resistance. Now, when they started testing vascular and endothelial growth factors, I believe they were trying to limit blood supply to the tumor, thinking that may slow or inhibit its growth. But what they found is that VEGF inhibitors actually normalized the tumor vasculature, which it had the effect of improving tumor oxygenation and drug delivery. So while that was good, and there was a positive treatment effect, the limitations being that this is a transient change that happens, and which may limit the clinical utility of that treatment for a long time, or over the long term. But circling back to exercise, we know that both acute and chronic exercise will improve tumoral perfusion, vascularization, and hypoxia in both mouse and prostate tumor models. The questions then become are, if we can normalize the tumor microenvironment, can that improve treatment outcomes? Can it reduce the progression of, or limit the progression of tumors? So Alison Betoff-Warner did this research at Duke. She's now at Sloan Kettering in New York. She did a randomized preclinical study with 2 different strains of mice, randomizing 11 to 12 animals per exercise or control group. They measured tumor volume, running distance, and body weight 3 days a week up to 18 days, and the exercise exposure was voluntary wheel running, so the animals could run or not whenever they chose. And what they saw was, compared to the sedentary group, the animals who trained had significantly smaller tumors at the end of the 18 days. So there seemed to be a suppressive effect there. But then they wanted to know why. So when they looked at some of the causal pathways, they saw that exercise improved a number of factors, including apoptosis, microvessel density, vascular function and maturity, decreased regions of hypoxia, increased VEGF expression, and better tumor perfusion. And I think it's clear to see that if you look at the tumor perfusion, or how colorful the sedentary animals are, or the tumors of the sedentary animals are, versus the trained animals, I think you can see quite plainly that perfusion was better in that exercised group. But then they wanted to know how these changes might impact treatment outcomes. So they had a similar sort of randomization, but they randomized animals in this case to 4 different conditions, one with no treatment, one with chemotherapy only, one with exercise only, and one with a combination of exercise and chemo. Similar measurement patterns and similar training exposure. And what they saw was, between the 4 groups, the animals that received the chemotherapy injections were dosed at days 7, 9, and 11. And what they saw was that compared to all the other groups, the animals treated with exercise and chemotherapy had the smallest tumors at the end of that training period. And that both the exercise-only and the treatment-only arms had a similar suppressive effect on tumor growth, which I think is pretty interesting. So hopefully this stimulates some ideas of how we might be able to use or couple exercise with treatments to improve treatment responses. Now, a different model looking at exercise in prostate cancer. So we know that exercise increases NK cell mobilization and infiltration within different tissues, especially into tumors, and there's preclinical evidence that it suppresses the growth of tumors. But when we look at an advanced disease, when we look at that effect in an advanced disease context, we see that NK cell activity actually suppresses one of the main pathways of enzalutamide resistance, and further decreases metastatic castrate-resistant prostate cell invasion into other tissues. So both in an earlier stage disease and in a later advanced stage disease, it appears that exercise may have a supportive effect at improving outcomes and reducing treatment resistance. Looking now at the late effects. So I'm going to share with you some of my PhD data, and I don't have time to unpack all of the data in the way that I would normally like to, but I will say that I will move through it quickly in order to get to the highlights at the end. So looking at late effects in the context of testicular cancer, the 2 major sort of areas of concern for this particular group are late occurring cardiovascular disease and fatigue. So we looked, our study sample included 64 community-based testicular cancer survivors between 18 and 80 years of age with should be no evidence of preclinical cardiovascular disease. We excluded people who were unable to complete the first 2 stages of our cardiopulmonary exercise test, had any degree of significant uncontrolled comorbidity, and were currently vigorously exercising. Of the 900 we approached, we randomized those 64, lost 1 at post-intervention, and lost about, I think, 8 or 9 more at 3-month follow-up. But we assessed physiologic outcomes only at baseline and post-intervention, and we assessed patient-reported outcomes across those 2 time points as well as at 3-month follow-up. Our intervention was 12 weeks of high-intensity interval training, and you can see that over the first phase, which encompassed a 4-week period, we progressed the intensity from 75 to 85% of their baseline peak. Over the second phase, which was another 4-week block, we progressed them to 90%, and over the third phase, they were training at 95% of their baseline value. But we know that there's some adaptation occurred during the first couple of weeks, so they probably weren't training at quite that intensity. A primary outcome is relative VO2 peak, which is a strong independent predictor of mortality across multiple clinical populations. And we looked at secondary novel and traditional cardiovascular disease risk factors, including arterial structure, nervous system reactivity, different blood-based biomarkers, Framingham risk score changes, as well as the prevalence of cardiovascular disease risk scores, or risk factors, pardon me. We also looked at a number of patient-reported outcomes, including fatigue, health-related quality of life, anxiety, depression, self-esteem, stress, and sleep. And again, I don't have time to get into this fully, but look at all of the things that improved to a significant and oftentimes clinically meaningful degree on the cardiovascular side. Cardiovascular fitness, decrease in Framingham risk score, improved vascular health, nervous system function, and some important biomarkers. Overall, just a 12-week intervention elicited significant and clinically meaningful improvements across a number of cardiovascular outcomes, and an overall 20% decrease in the prevalence of modifiable cardiovascular risk factors. On the patient-reported outcome side, at post-intervention, there was improvements in cancer-related fatigue and self-esteem, as well as a number of health-related quality of life outcomes. The pattern was somewhat unexpected because most of the studies to date have showed that the more physical aspects of quality of life tend to improve with exercise, but we saw more mental aspects of quality of life improve, which might be related to the nature of the deficits in this population. At 3-month follow-up, only fatigue and vitality, which is the health-related quality of life construct most closely related to fatigue, both of those outcomes maintained their benefit, or there was a sustained effect at 3-month follow-up. We also did some exploratory analysis to see what effect our intervention and our primary outcome may have on some of our patient-reported outcomes. So we looked to see what percentage of change in some of the dependent variables were explained by changes in VO2 peak. And we saw that at post-intervention, VO2 peak explained a significant portion of change in mental component score, vitality and mental health, as well as fatigue and vitality at 3-month follow-up. So that gives us some insight into some of the underlying mechanisms by which the intervention may improve mental health and fatigue-related outcomes in this group. And it also underscores the importance of improving VO2 peak with our interventions when we're trying to improve some of these other patient-reported outcomes. We also did a moderation analysis and saw that testicular cancer survivors with low fitness at baseline, who were clinically fatigued at baseline, had higher testosterone levels, and who were not meeting the guidelines, tend to benefit the most from the intervention. Again, this gives us insight into some high-risk or high-need patient groups that could potentially serve as precision exercise intervention targets. But the real data is in the individual patient data, getting back to the theme of today's talk. So if we look at our primary outcome, we see that on an individual patient data level, this is the threshold for a minimal clinically important difference. We see that we have different bins of sort of low responders, moderate responders, and high responders. Now, what I'm encouraged by with these data is that there is, even though the magnitude of improvement is not consistent, so that is something we could potentially address with a precision prescription, at least the direction of change was consistent. And when we compare that to what happened in the usual care group, this is a fairly typical pattern of what you would see in most intervention responses and in usual care conditions over time, right? Some people will get a little better, some people will get a little worse, and it should sort of average out to a null effect over time. But look at the difference in that pattern of effect versus our inflammation effect. We reported a significant difference in C-reactive protein. But it is not apparent to me, other than a couple pretty good outliers, it is not apparent to me that the intervention really had a huge impact on this. So I'm less convinced that HIT is a good strategy to improve inflammation in this particular context. So we might need to explore other outcomes if that's really what we're targeting. And the fatigue data looks somewhere in the middle, where most people still had some benefit with the HIT group, but there was at least about a third of patients who didn't really benefit from a fatigue perspective at post-intervention. So there's likely more we can do for these patients, and it'd be really interesting to characterize who responds versus who doesn't to start tapping into why they are not responding to these interventions. Getting into the last phase here, how we might optimize survival with targeted prescriptions. So we recently published a study looking at the association between exercise and mortality of adult survivors of childhood cancers. So in that population, this group was treated between 1970 and 1999, and they were an average of about 18 years post-diagnosis. When they filled out their baseline questionnaire starting from 1992 onwards, we had data on about 15,000 patients or survivors, and we tracked their mortality rates up to 20 years follow-up. We were also interested in change in behavior over time, so not just that single cross-sectional snapshot. Sorry, this is how we collected our mortality data. So on average, between the two time points, there was about 10 years difference between questionnaire 1 and questionnaire 2. And we had data in about 5,600 survivors in the second questionnaire looking at change in exercise behavior over an 8-year period. And the exercise behavior that I'm talking about is engagement in vigorous exercise. So looking at our baseline exercise and exposure, our baseline exercise exposure and its effect on mortality risk. We saw a nonlinear pattern of response when we looked at the mortality risk reductions in the sort of artificial MET hour per week bins that we created. So we let the data fall sort of more naturally instead of imposing these sort of bins on it. And we saw that somewhere between 15 and 18 MET hours of work per week seemed to have the greatest protective effect in terms of reducing mortality risk. So then we compared individuals who were sedentary to individuals who were performing between 15 and 18 MET hours of work per week. And we saw that there was a significant decrease in death from any cause, no change in death from recurrence or progression, and another significant decrease in death from health-related causes. Overall, we saw that vigorous exercise was associated with a 42% risk reduction in all-cause mortality. But remember, we were also interested in whether or not changing an exercise behavior has any additional effects. So again, we looked at 5,600 survivors, about 8 years between the two questionnaires. Our low maintenance group, so the group that was sedentary at baseline, or performing no vigorous intensity exercise at baseline, and maintained no vigorous intensity exercise at follow-up, was our reference group. So we see that individuals who started doing exercise and decreased by 6 MET hours per week, so about an hour of actual exercise, and those that decreased, there was no real effect on survival. But in individuals who increased their exposure, so the individuals who were doing nothing, and increased by just 6 MET hours of work per week, had about a 40% risk reduction in all-cause mortality. That was similar to the group that was the high maintainers. So they were doing it baseline, and they continued to do it at follow-up. So just adding 6 MET hours of work per week can have a significant impact on reducing all-cause mortality. And I think this is a really important message for our patients, that it's never too late to get moving. Even if you've been sedentary before, just by adding 1 hour of vigorous intensity exercise in your week, you can have a dramatic risk reduction. So we were excited by this. But we didn't break it down into sort of different subtypes of disease. So another study by Lee Jones looked at the interaction between exercise and prognosis according to different subtypes of disease in 2 large cohort studies, the LACE and pathway studies. They had data on about 6,200 individuals treated with who had early-stage breast cancer. These were both prospective cohort studies, and they classified patients according to their different tumor subtypes. Their primary outcomes of interest were breast cancer recurrence, breast cancer-related mortality, and exercise quantified in MET hours of work per week. And when they just looked at the proportion of patients who survived based on different levels of exercise, they didn't really see a difference between any of these exercise groups. But then they unpacked it a little further, and they looked at the association between exercise and breast cancer recurrence according to different clinical pathologic features. They didn't see any significant differences there either. They also looked at the association between exercise and breast cancer-related mortality, according to those same features. And what they did see is that patients who had smaller tumors benefited significantly more in terms of risk reduction than individuals who had tumors greater than 2 centimeters. They also saw that even though, say, for example, the well-differentiated, well to moderate differentiated tumors was not significantly different from the poorly differentiated tumors, that there was a significant risk reduction sort of from baseline, just not between the comparison group. And that was the case for those well-differentiated tumors, ER-positive and HER2-positive tumors. And then lastly, they looked at the association between exercise and breast cancer-related mortality according to different clinical subtypes of the disease. And in both cases, they saw that the ER-PR HER2-negative group had a significant benefit to engaging in exercise, whereas some of the other tumor subtypes didn't. This is exploratory, but it gives us some initial sort of signal-seeking data to suggest that subtypes of disease may be more or less responsive to our interventions than others. What he said. And I think, too, that this may explain some of these sort of differential responses we see in these larger sort of prospective cohorts and retrospective cohorts, where we see sometimes exercise does or sometimes it doesn't have an impact on mortality. So to wrap things up, we know that some of the conditions our patients face are complex in their etiology, and that exercise likely can positively impact many of the different pathways or factors driving these conditions. The one-size-fits-all exercise prescription, although it will work for some people, does not work for all patients. So I think we as a field could do more to figure out who the responders and non-responders are, who the high-risk and low-risk patients are, and get more people across the finish line. By adopting a precision medicine approach, we can better characterize our patients, identify these unique subgroups based on risks or responses, and develop targeted intervention strategies, multimodal intervention strategies, to really address the underlying deficits and needs in these patients. And I hope I've at least given you something to think about in terms of how we might apply a precision exercise model, medicine model, across the continuum for our patients. I'd like to wrap up by thanking the team at U of T, Kathy, Daniel, and the whole crew, Jennifer and the team here at Elixir, Lee and Jessica, who really got me thinking about all this stuff at Sloan Kettering, and of course, the boss, Karen Kernia. Thanks very much.